Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. We're so pleased that you're spending some time with us at the event, The Care We Need, the National Quality Forum, and 20 Years of Quality. This event is occurring in conjunction with the release of a report by the NQF that they've released in advance, but we're also publishing some blogs today that offer additional commentary on the topics covered by the report. We have a terrific panel for you and an incredibly important topic, and I look forward to moving into the content of the discussion. We're always excited with our events. We have fun with them and they cover important topics, but today's is particularly near and dear to my heart. And so I'm going to take just a moment or two to tell you a little about why that is before we get into the content. So what became the National Quality Forum arose from the work of a commission appointed by President Clinton. It was called the Commission on Consumer Protection and Quality in the Healthcare Industry. It was chaired by then HHS Secretary Donna Shalala and Labor Secretary Alexis Herman. There were some really amazing, wonderful, talented people on that commission. Names that I'm sure you would recognize: Mary Wakefield, who is one of our panelists today. I'll introduce her in a moment. Rizal Avisa-More, who subsequently became the President and Chief Executive Officer of the Robert Wood Johnson Foundation. Don Berwick, then the President of the Institute for Healthcare Improvement and subsequently the CMS Administrator. Kathleen Sebelius, who was at the time the Insurance Commissioner for the state of Kansas. She, of course, became governor and then Secretary of HHS. The list goes on and on. There's one name that was a member of that commission who is me. And in fact, I got to meet a lot of those amazing people through my service on the commission. And so I feel like I was a little bit there at the founding and part of the conversations that led to the creation of NQF. And so that's why today's event is particularly special. It's a little hard to believe it's been 20 years, but here we are. And the funny thing is, when I think back to the work that we did as a group, think about the title of our commission. It was Consumer Protection and Quality. We were already at the time tying together the consumer and patient side with the healthcare sector and quality and measurement. And that, I think, has only grown with time, but maybe we were a little bit ahead of our time. And so the connection of consumers and quality was baked into the work from the outset. The other thing I remember very clearly is that at the time, when people talked about quality, the primary emphasis was on medical errors. There was the notion of 2 airplanes crashing a day where the number of deaths caused by medical errors. Now, clearly the issue of medical errors is still with us, but our understanding and conception of quality has grown so dramatically since those days so that we're not just talking about errors. And at the time, we used the language of underuse and overuse and appropriate use. But now we have such nuance, such granularity in the data, in the way that we think about these concepts. We look at processes, we look at outcomes, we look at inputs, we look across settings, care settings, we look at different patient populations. And so the progress in the quality enterprise has really been quite amazing. But I went back in advance of today and I looked at our report. And we talked about what this entity that we were going to be creating, that we were calling for the creation of, was going to do. And we said that we were recommending a series of steps that should be taken primarily by the private sector to bring order to the current system of quality measurement while continuing to encourage development and innovation. And here are some of the things we said we needed. Core sets of quality measures applicable to each sector of the industry. We talked about the industry supporting focused development of quality measures that enhanced our ability to evaluate and improve healthcare. We talked about the steps that needed to be taken so that comparative information on quality is valid, reliable, comprehensive, and available in the public domain for use by consumers, purchasers, practitioners, quality oversight organizations, and others. Well, if you ask me, we've done a lot of that. The quality enterprise has taken this charge very seriously. Of course, we have a long way to go. We always look to what the future calls for. But it's really gratifying for me to be able to look back at the work we did more than 2 decades ago and say that we put out a roadmap. The nation followed that roadmap. But now we come to a time where NQF chose to pull together a process that you'll hear about in just a few minutes, to look not just backward at what we've accomplished, but forward to where we need to go. And that's what's captured in this report. And that's what we're going to discuss today. We'll take a little bit of a look backward, but we're really going to look forward. And what I'm struck by, and I'm sure you each will have your own observations, is that the core need for a robust quality enterprise is still there, and it's something that I think we can all agree upon. But the specific steps to be taken, we're now building on a 20-year platform. We have so much of a more solid foundation today than we had when we issued our report a couple of decades ago, and that just gives new opportunities for how to take the next step. And figuring out what those next steps are is what's captured in this in the NQF report. In the blogs that we're publishing today, as well as what our speaker is going to talk about. So I hope you can understand why I was particularly excited to be able to host this event. But I'm not the main event. I'm just a little bit player in this story. You're going to hear today from 4 leaders in the field. You're going to hear from Shantanu Agarwal, President and Chief Executive Officer of the National Quality Forum. He's a board-certified emergency medicine physician, and he's the leader of NQF today. You're going to hear from Ken Kaiser, Chief Healthcare Transformation Officer, Senior Executive Vice President of Atlas Research. He has very deep experience in this area, but in addition to having served as the Veterans Administration's Undersecretary for Health, he is the founding president and CEO of the National Quality Forum. So he took the charge from the commission that I was discussing, and he launched this enterprise. And so his historical perspective, as well as current expertise, is tremendously valuable. We're going to hear from Mary Wakefield, who, as I mentioned, was a co-commissioner with me. She's visiting distinguished professor in the practice of healthcare at Georgetown University, visiting professor and distinguished fellow at the University of Texas at Austin. Formerly, she was the administrator of HRSA, the Health Resources and Services Administration, which is a part, of course, of HHS. And I had the privilege just last year of being in the audience as Mary was recognized as a living legend of the American Academy of Nursing. I was out in the audience when you received that honor. So it's great to have you with us as well. And Carolyn Clancy is the Deputy Undersecretary for Discovery, Education, and Affiliate Networks. I love that acronym. It's DEAN. She is kind of the Dean of Healthcare at the U.S. Department of Veterans Affairs. She has been the Director of the Agency for Healthcare Research and Quality, AHRQ, which is, of course, has played a critical role in the quality enterprise in the United States. We have both historical and forward-looking speakers today, and I know that they're going to cover this topic extremely well. So to kick it off, let's turn it over to Shantanu Agarwal, President and CEO of the National Quality Forum. Shantanu?
Alan, thank you. Thank you for those great reflections, and it's really wonderful to be on this panel. I am actually going to turn it over in a few seconds to Ken to actually kick off the presentation, which we will be doing together. One thing I just want to note at the outset is I constantly in my work at NQF, of course, meet organizations and meet with their leadership. And I am told by many, many people that they served on that original committee that helped to create NQF. So many people, in fact, that committee would have to be thousands large. And I always thank them. I sincerely appreciate it. What that tells me is just how incredibly invested people are in the success of this organization. It is actually extremely heartwarming every single time I hear that. So it's great, once again, to be reminded about the origins of NQF and to hear from so many voices that truly served on that original committee. With that, I'm going to ask Ken to be my co-presenter and to kick off our introduction.
So thank you, Shantanu, and thank you, Alan, for that kind introduction, and as well as your, I guess, paternal role in the creation of the NQF. And thank you, everyone, for joining with us this afternoon. Let me start off by just setting the stage for what we hope to cover during our time together this afternoon. So if I could have the first slide. So I think I should first note that, as Alan has already said, that due to the hard work of numerous organizations and really innumerable individuals, very significant advances in the quality of American healthcare have occurred since the NQF was founded back in 1999. Perhaps most especially in the areas related to preventing medical care harm. However, I think those of us who have been in this for quite some time recognize that very significant problems remain. Frankly, we've not achieved what we had hoped we would achieve by 2020. And the National Quality Task Force was created in large part with that realization in mind, and with a purpose or a vision of charting a course to where every person in every community could expect to consistently and predictably receive high quality care with every encounter with the healthcare system. Before we launch into the specific findings of the task force, let me offer a very quick review of some of the key events and circumstances that led up to the creation of the National Quality Task Force. If I could have the next slide. And I think just as a little background to the slide, it's important to note that concerns about the quality of healthcare go back a long time. Indeed, in the written record, they go back at least 4,000 years to the Code of Hammurabi in Babylon. But time really doesn't allow us to talk about all those things and to turn the clock back that far. So we're just going to turn the clock back to the 1990s. And throughout the, particularly the latter 1980s and the 1990s, quite a number of things occurred that catalyzed the modern quality movement, as we call it. Particularly in the mid 1990s, a confluence of circumstances, but especially several quite devastating high visibility medical care errors, combined with some what might be considered rather egregious high visibility managed care practices, resulted in healthcare and healthcare quality really being put under the proverbial microscope. And what we saw was problematic. Which resulted in a number of reports, as reflected here on the slide, the cover from the commission that Alan mentioned. Prior to that, there was a report and a review of quality of care by the Institute of Medicine. I was pleased to be a member of that, the National Roundtable on Healthcare Quality. There was also a number of other ones, the report by Bob Brook and Beth McGlynn and others on looking at the state of healthcare quality, but especially the Institute of Medicine's report To Err Is Human that was released at the end of 1999. So really the high rates of medical errors, the limited culture of quality combined with rising healthcare costs, the disparities, which were increasingly being recognized at that time, the lack of data, lack of transparency, really resulted in a major shift in what we were doing in the area of healthcare quality. If I could have the next slide. And we have perhaps arbitrarily thought about and divided the last 20 years or so into kind of 4 different stages, which really began with much of what I've already talked about, where the problem was defined in much greater detail and more granularity than it had been in the past. There were several reports, including one I'm going to focus on a little bit more in a moment, the Institute of Medicine sequel to the report to Eris Human, Crossing the Quality Chasm. And the National Quality Forum put forth a framework to look at national quality improvement. And these stages are really somewhat arbitrary. They're overlapping, but there were some different events that allow us, I think, to reasonably think of it in these stages. And the second stage was really characterized by starting to measure in a serious way. ARC and CMS and Carolyn Clancy, who was heading the Agency for Healthcare Research and Quality at that time, is going to join us in this panel. CMS really built upon the work of the Joint Commission, the NCQA and their pioneering work with HEDIS, the work that the NQF was doing, as well as work from the Institute of Healthcare Improvement, and a number of other things happened that really moved the measurement agenda forward. If I could have the next slide. So I already mentioned the Institute of Medicine at that time, now the National Academy of Medicine, but their report on Crossing the Quality Chasm, one of several seminal reports that the Institute put out in those years. And I just want to highlight that in that book or that report, they identified 6 aims for quality improvement and 10 rules for redesign of the healthcare system. And I'm not going to take the time to go through each of these, but I would say that these have really provided a very good roadmap and been the foundation for so much of what has occurred over the last 20 years. As Shantanu will talk about, some of these things have been tweaked a bit, and there's some terms that have are used now that are a little different than what was espoused in that book. But this really has remained a guiding document for quality improvement across the country, indeed, in much of the world. If I could have the next slide. So this kind of moves us to the last or the next 2 stages of what we have called the modern quality movement, beginning around 2004, 2005, particularly with CMS. Transparency and reporting really took a leap forward with things such as the Hospital Compare website. The NQF by that time had already promulgated or endorsed quite a large number of consensus standards or measures, and these really began to be widely used by employers and purchasers and others throughout the healthcare industry. And then this was followed shortly by a greater focus on linking the outcomes or the results of those measures to payment. And a number of events occurred associated with passage of the Affordable Care Act and a number of other legislative actions since then that have tried to use payment to move the dial on quality of care in the U.S., which this very quick journey through the last 20 years leads us to the next slide, which is kind of where we are today and really the foundation for much of the thinking that led to the creation of the National Quality Task Force. Despite the improvements and significant improvements that have occurred in improving quality of care, reducing medical error rates, these things are still not to the point where we think they should be. Costs continue to rise disproportionate to the rest of the economy. Certainly, recent events have shown a spotlight on the widespread healthcare disparities that exist and the overall lack of sufficient transparency in the system. Our data, and despite all of the measures, we still have siloed data. We have concerns about professional burnout and the number of measures and the difficulty in procuring the data to report the measures, as well as, again, the increasing cost of care and the increasing amount that consumers have to bear in that cost. So recognizing I've left out a lot of things in this quick overview of how we got to where we are today. But hopefully this provides some context and will lead into where Shantanu is going to take off with the National Quality Task Force and what we did. Shantanu?
Great. Thank you, Ken. Next slide, please. So the history that Ken provided really was the foundational context for launching the National Quality Task Force, which Ken and I co-chaired. We undertook this effort in throughout 2019 and obviously published the report then recently. Our main goal through this task force effort was to surface real actionable opportunities to improve the delivery system so that we achieve better health outcomes and value for every person. As we discussed it on the task force, the real aim, the vision, was normalizing high quality, high value care. As both Alan and Ken have indicated, there's clearly been progress made over the last 20 years. There have been some, I think, very significant wins in the quality improvement enterprise. And yet it is not the case today that every person really receives high quality and high value care every time they interact with the delivery system. So this was really the mission and the vision that we put forward at the launch of the effort. Next slide, please. We conducted the effort through 5 subcommittees, and I'm just letting you know a little bit about the structure, not that the structure is terribly interesting, but so you understand how we parse the work and what we chose to emphasize. Again, a lot of that being very consistent in themes with the work of the IOM and others 20 years earlier. We did, I should note, really continue on the thread of the IOM. So the 6 goals, for example, that Ken has discussed, we believe that those continue to be the right goals for the delivery system. We feel that they did truly stand the test of time. There are a couple of modifications that we've made in an effort to recognize today's challenges, which I will get to. But very much the context for the task force is the history that Ken laid out. The 5 subcommittees, so the first was really focused on promotion and system change. And we asked this committee to focus on those structural, cultural, and behavioral changes that were necessary to drive an aligned and high-quality learning system, which we in particular felt at the time of creating the task force. The learning system concept, while around for a while, really, again, itself was not universal and had not been adopted throughout the delivery system. Second, our second committee focused on consumer and community-driven care, with a particular focus on measurement, as you might expect from the NQF, but how to make measures more person-centered and consumer-defined and driven, while still retaining the important scientific properties that we have been assessing for the last 20 years in measurement. Next slide, please. A third committee focused on technology and transformation, and really the major question in front of this committee was how to decide when new technologies in care delivery, in perhaps artificial intelligence and other kinds of technologies that are clearly emerging, how to decide when those technologies should be adopted so that we are in healthcare neither lagging where we should be moving more quickly. And I think perhaps to many in the audience, that tells a little bit of the telehealth story, but at the same time, not getting ahead of technology adoption, perhaps better or more quickly than what the data would suggest or what the evidence would suggest. So I think both of those are terribly important considerations in deciding when and how to integrate new technological changes. A fourth committee really focused on payment and policy, again, driving, as we have seen over the last decade, continuing to drive and align performance incentives, with quality measurement and quality improvement. And in particular, we asked this committee, as we did, frankly, all the committees, to take on the issue of health equity and address the social determinants of health as well. And our fifth committee really focused on clinical and quality alignment. And that is in particular how to make sure that the work of quality improvement and of quality measurement really aligned with clinical priorities and the clinical workflow. And here, I think we were specifically seeking to address the various challenges that have come to the fore on burden of quality measurement and improvement activities, and clinician dissatisfaction with some of these efforts. One thing I will say just about the structure is we also did provide an avenue for a number of expert advisors to provide input on this work as we were going through it. And in total, this effort involved about 100 individuals and organizations taking a very diverse and multi-stakeholder approach that has been the hallmark of NQF since its founding. Next slide, please. So as I mentioned earlier, while the foundation of this truly was the work of the IOM and others from 1999, and while we retained the 6 IOM goals largely through this effort, there were 2 goals that we felt needed to be altered or tweaked in order to accommodate current issues and challenges within the quality enterprise. The first, while safe, timely, efficient, equitable care are all absolutely necessary and are clearly hallmark features in the quality enterprise today, we decided to alter the effectiveness or the effective aim to be appropriate. And that is, I think, to really address the issues of over and underutilization that have been discussed at length and as well, have been highlighted by various payment reforms. So wanting to make sure that we really were driving towards standards of appropriateness in the kinds of interventions that are done, the setting in which they are done, and ensuring that we are working to meet as a broad system the unique considerations and goals of individuals. And the second aim that we altered was moving patient-centered to person-centered. And that really was to recognize that in order to truly achieve health of individuals and populations, we had to recognize the whole person whose health we are working to improve, and to be inclusive of physical and mental health, of social determinants and other health disparities, and ensure that we are providing comprehensive well care. So again, I think 6 really important goals from the IOM with 2 modifications to accommodate current challenges. Next slide, please. There were 5 main strategic objectives that came out of this work that you will see in the report, The Care We Need. And again, I think very reflective of the themes that we've been discussing thus far. First is ensuring that we have appropriate, safe, and truly accessible care. Second, that we are implementing the seamless flow of reliable data, and a host of recommendations I think really get at this strategic objective. Third, that we are supporting activated consumers who can then be involved as decision makers and choosers in their own care. Fourth, that we are achieving actionable transparency. And finally, that we are paying for person-centered care and healthy communities. And again, a lot of that was to accommodate the inclusion of addressing social determinants and health inequity issues. Next slide. I'm going to really conclude with 2 slides that quickly cover the main recommendations or opportunities from this report. We divided them into 2 categories, those that we viewed as a task force as being absolutely foundational. Without these recommendations, it was hard to envision significant improvements to the enterprise really taking hold and moving the enterprise forward. So first was establishing a single person identifier so that essentially patient information can follow the patient or the person across all different kinds of care settings. Second, standardizing quality data, including importantly quality measures, so that there is true transparency and comparability across all of the different sites of care and services. Third, that we continue to adopt population health-based payment models as the primary payment model. And here the task force really did largely align with LAN goals that have been promulgated already, but focus on population health, population-based payment as the primary model. Fourth is standardizing data and interventions to reduce disparities and achieve health equity. This was a very cross-cutting theme in the work to ensure that equity was always top of mind and being addressed in the work of the task force and its committees. And finally, to create actionable intelligence to better educate and engage consumers. I think if you were to look at these foundational recommendations or opportunities, the central theme is moving away from the hyper-fragmented approach that we have today, where there is lack of alignment of measures, lack of availability of data, lack of the interoperability and the portability of data, and making sure that we are solving these issues on an inherently structural, foundational level. Again, it's hard to imagine, really catalyzing the quality improvement enterprise without solving for these core issues first. Next slide, please. I think where the foundational opportunities really speak to a centralized infrastructure, the accelerators, these additional 5 opportunities, I think directly address the culture of and delivery of care. So the first opportunity in this area was ensuring that advanced technologies that are adopted by the delivery system really are aimed at improving the safety of care and the appropriateness of care. I would emphasize that the underlying this recommendation is the need to establish a technology evaluation framework, specifically so that quality, safety, and appropriateness are front and center in determining when a new technology or an emerging technology is really adopted in healthcare, as opposed to other considerations that might lead to adoption today. Again, we should neither be laggards in healthcare technology adoption nor out ahead of the evidence. The second opportunity is to integrate virtual and innovative care modalities throughout the delivery system. Notionally, this opportunity really gets at the issue of telehealth and other kinds of virtual care to ensure that we are really making access possible for we're making access possible across the delivery system for all patients, regardless of where they need that access or how they need it. The third recommendation is continuing to improve access by recognizing clinical licenses across the country. Taken together, these first 3 recommendations are really about patients getting the care they need, when they need it, from whom they need it, that is able to provide them the highest quality, high value care. The fourth recommendation is, and fourth and fifth, I would argue, really speak to the culture of the delivery system itself. The fourth focuses on accelerating the adoption of leading practices. Again, if you think about normalizing high quality and high value care, being able to identify what the leading practices are from a very evidence-based perspective and having them actually be adopted throughout the system becomes very critical. And finally, cultivating workforce competencies and actually providing the care that we want to see, which is safe, appropriate, and person-centered. Next slide. So as Ken really pointed at, there are challenges that in some respects persist from 1999 and some that are new to the enterprise that we really aimed to solve through the work of this task force and to really identify a roadmap looking forward. I think it's worth noting that, of course, while the work was done pre-COVID, a lot of the lessons that we have tried to bring forward, I think, certainly do apply in this COVID world. We were particularly, I think, astonished that in the task force about the rapid adoption of telehealth during this period, as well as licensure flexibility. Both of those recommendations from the task force felt at the time that we were writing them to be huge barriers that they would take a lot of work to execute. And in fact, we have seen a lot of those barriers come down dramatically. This is progress that I would argue we need to continue to make to ensure that the lack of availability of telehealth and licensure rigidity does not stand in the way of making sure patients can get access wherever and whenever they need. And we have certainly seen over the last several months the widening gap in disparities that the pandemic has produced, certain challenges to our core business models, such as our supply chain in healthcare. We have taken physician burnout or clinician burnout and gone from just sort of a burnout issue to really threatening the health of our healthcare professionals and others through inadequate PPE supplies, for example. And finally, I think we continuing to see the need for technological innovation so that we are responding to the needs that really face healthcare today. So that is the introduction, I think, to the task force, and just sort of lays out the broad recommendations that we've made. And I will turn it back over to Alan now. Thank you.
Thank you, Shantanu and Ken. Now that you all have a sense of what's in the report, we're going to hear responses and reactions from Carolyn Clancy and then Mary Wakefield. I do want to remind viewers that we will move into a question session after these next two presentations. The sooner you submit your questions, the easier it is for me to review them and tee them up for our conversation. The question box is right below the screen where you're watching us. And so I encourage you to feel free to submit those in real time. You can, of course, do it later, but the sooner they come to mind and come to me, the better. I'll turn over now to Carolyn Clancy for some reactions to what we've heard. Carolyn?
Well, thank you so much, Alan, and I'm very, very appreciative of the opportunity to be here today. Some of you know that I'm from Boston, and it's a big hockey town, so skating to where the puck needs to go is a very big theme of my childhood and growing up, and I think that's exactly what the National Quality Forum led with this report, and you're to be congratulated on that. To touch on a couple of points of history, in late 1999, several things happened all at once, or it felt like all at once. One was that what had been the Agency for Healthcare Policy and Research became the Agency for Healthcare Research and Quality, and we were directed very concretely to lead a number of activities in quality and safety. That was followed within a week or so by the launch of the report To Err is Human, and it's all around the same time that we had the birth of the National Quality Forum. So quite a banner year. We got to work right away, and it's very instructive, I believe, that many of the successes quoted at the outset of the prior presentation are all about safety. And I think in big part that's because it mattered to people and they actually understood and cared a great deal about what was happening there. I want to pick on, just focus on three major themes in the report that I found very, very important. The first is what I would call meaningful patient-centered data. I don't think anyone would say that we have too few measures now. We have boatloads of them, in fact, arguably way too many. But if we can't identify the most important components of patient care and measure that, the result is precision without purpose at best and complete chaos at worst. It is really long past time for quality measures that matter to improve patient care and those that are derived from real-time data. You know, the past 2 decades have brought amazing changes in care delivery. Care that we routinely thought of as hospital-based care is now being delivered outside the hospital walls in outpatient settings, ambulatory surgery, and even patients' homes. And coupled with the emergence of smartphones, remote monitoring devices, multiple types of virtual care platforms, and social media, you know, our ideas of what's possible have also expanded. So the NQF Task Force's vision that data must be available from multiple sites is an essential step forward in achieving person-centered rather than facility-derived care. Linking these data to clinical actions across widely distributed settings is integral to getting the right measures, and I would argue the measures that all of us care about. A second theme I want to just touch on is expanding telehealth services. As Alan said, or Shantanu, it is just utterly amazing how rapidly that happened. As Mark Smith said, the whole health system went from high touch to no touch almost overnight because we had to minimize risk to patients. So in the very early days of the pandemic, VA's Office of Connected Care greatly expanded our telehealth services for veterans. It's very important to know that prior to the pandemic, we had a robust suite of telehealth services in more than 50 clinical specialties. So what that meant was we were building from a strong foundation, and over a 4.5-month period, we've increased our telehealth services for veterans by over 1,100%. This is very, very important in our system because a third of our veterans live in rural areas, and it's also hugely important in the context of natural disasters, unlike infectious pandemics. And we now know that telehealth can be a total game changer in the face of a global pandemic like COVID-19. A third theme I want to touch on is health disparities. There have been many articles and reports showing that members of the African American community and other minority groups have been disproportionately impacted by this virus. Our data on patient demographics and COVID-19 in VA is very much in line with national trends. Specifically, our data indicate that African American and Latino veterans are 2 to 3 times more likely to test positive, but there are no differences that we have seen yet in mortality rates, which we think of as good news. We also know that African American veterans who get care in our system are more likely to live in high-density cities in the U.S. where COVID-19 has been more prevalent, although it's also spreading to rural areas. And it's also likely that many of them work in essential jobs where teleworking from home is not even thinkable. So the increased risk of coming into contact with people who are infected is a big deal. With the power of big data now, we can make all kinds of maps and hone in at very, very small community levels. Our big challenge right now is how do we translate that information on risks to practical operational strategies to improve outcomes. I also wanted to take Shantanu's lead and just make a few points about this pandemic. I think that we have learned some very important lessons on how to respond to a disaster of this scope and urgency. And as many people have observed, it has provided a lens that magnifies the pre-existing weaknesses in our healthcare system in this country. So a few areas we need to consider and focus on. One is assessing flexibility of systems of care. A second, which I think has been left out of the first 2 or 3 eras of quality assessment and improvement, is linking quality assessment to public health preparedness. We should be proud of the improvements we've made in patient safety, but if worker safety isn't part of that, and I mean all healthcare workers, we have not met the goal. And I would also argue that some of that safety is having predictability and some certainty that I can get the protective equipment, that it'll be there when I need it. Focusing like a laser on health equity, including social determinants of health and disparities in care delivery. And ultimately, I think the most important roadmap for quality has got to improve all healthcare workers. That includes ambulance drivers, first responders, and so forth. So in order to respond quickly and effectively to future public health emergencies, we have to improve the infrastructure that underpins the system overall. And quality improvement is a vital component of this foundation. You're not going to be ready in a crisis unless you have tested the system previously. So again, thank you for the opportunity to be here, and I'm very much looking forward to questions.
Thank you so much, Carolyn. And now we'll hear from Mary Wakefield. Mary?
Thanks, Alan. When I first read the report, The Care We Need, I was really struck by how it advances a framework of clear, impactful next steps to achieve the identified aim of making safe, high-value care the norm for all people in all places. I also found striking how solidly the report builds on the foundation of quality and patient safety efforts that came before it, much of which Ken and Shantanu just walked us through. I'm going to focus my remarks on a few of those earlier efforts that provide part of the foundation and that also overlap with my areas of work in health policy, rural health, and health professions education. And I'll connect those 3 areas to features of the Care We Need report. My purpose in doing that is to illustrate how each of us, from our own vantage points, can think about how we're connected to and could engage in driving the components of this report forward. Not as a freestanding report, disconnected from work that's gone before it, but as a report that contemporizes and advances the quality and safety agenda. Looking back to the President's Commission on Consumer Protection and Quality, Alan, that you mentioned, there's one additional point that I want to make about it. As is the case today with the Care We Need report, there was substantive input from scores of individuals to inform that commission's report. I think this observation is worth underscoring That when it comes to issues around safety and care quality, pulling forward that thread of inclusion is critically important, including, of course, meaningful engagement of and with consumers. The report by the President's Commission was quickly followed by the then IOM report To Err Is Human, released late November 1999. And in a move that was lightning fast, just 2 weeks later, the policy arena engaged, with Congress holding the first of a number of hearings, responding to the report and also to the press that it garnered. The first congressional hearing, titled Medical Mistakes. Having been a member of the IOM committee that produced that report, I served as the IOM's witness. There were two recommendations, or one in particular in the report, that prompted questions directed to me. And those questions were, how did the IOM committee decide on the goal to achieve a 50% reduction in medical errors? And furthermore, what was the IOM committee's thinking about what needed to happen to achieve that goal? More than fair, these really were very important questions. By way of comparison, in the report, The Care We Need, there are clear, meaningful measures of success that are delineated with shorter and long-term timeframes, expressed with tighter focus. For example, one of the report's measures of success, over 50% of healthcare systems and payers reporting measurable improvements in outcomes tied to social determinants of health and other disparities. Today, there is more precision brought to constructing measures than there was back in 1999. At that moment in time, we didn't have the subsequent work of ARC and the great work, including, of course, of Carolyn Clancy and her colleagues. We didn't have the work of NQF and other organizations to build out the detailed parameters for measuring progress. And also, just to interject a lighter note, and to contrast the view of medical errors then versus patient safety problems now, another question that I was asked at that hearing: how was the problem of bad handwriting of physicians that were likely contributing to medical errors? How was that problem going to be remedied? Well, today I'd say a solution has been found, EHRs, which of course have issues of their own. But an alternative solution, Alan, could have been that physicians in this country had the benefit, as I did, of Sister Mary Aquin as their 8th grade teacher. And I can tell you, they'd have buffed up their handwriting in a hurry. Well, fast forward from that hearing to public policy opportunities today. Clearly, the policy arena continues to have an important role in achieving the goal of making safe, high-value care the norm by 2030. Here's just one example, a current policy connection that I could see being made, an example of a tactic to help advance the work embedded in the Care We Need report. Last year, the U.S. House Ways and Means Committee established a bipartisan task force focusing on the health of rural and underserved communities. Just a couple of weeks ago, they produced their first report, identifying 4 policy areas that will be directing their efforts toward. As I mentioned the 4 areas, you'll hear how they overlay with some of the very areas of focus of the Care We Need report. And so one could envision that what the NQF's work could bring to the House Task Force is an important added dimension to these 4 areas, a dimension that focuses, of course, on advancing safe, high-value care, in this case for rural and underserved communities. These are the 4 areas of focus of the task force. First, addressing social determinants of health, also a critically important focus of the NQF report. Second, enacting payment system reforms. The NQF report uses payment model approaches to normalize high-value care. Third, strengthening technology and infrastructure. Well, the NQF report has actionable opportunities targeting this area as well. And finally, policy strategies that reinforce the health workforce. While related to that, the NQF report speaks to workforce competencies. So an example of one potential fit between the focus of the Care We Need report and work being pursued in the public policy arena. The other 2 examples of where the Care We Need report builds on earlier work and can meaningfully help to advance it: rural health and health professions education. Regarding rural health, 15 years ago, the IOM released a report titled Quality Through Collaboration: The Future of Rural Health, This report was part of the IOM Quality Series and produced by a committee that I chaired. One consumer-oriented area of focus in that report targeted the need to improve health literacy of rural community residents. Today, the Care We Need report markedly expands from that and extends other work related to rural populations by recasting the focus on consumer engagement and patient experience. That, of course, can be used by rural health stakeholders. They can take the report related to those and other dimensions to help further shape the contours of their efforts. And then the last example, health professions education. Here again, there is a solid foundation that faculty of health professions programs have built on in educating around safety and care quality. Just one piece of that foundation was the IOM report, Health Professions Education, A Bridge to Quality. A physician educator, Ed Hundred, and I co-chaired that committee that produced the report. And here again, you can see the Care We Need report extending that and other work relevant to workforce education. For example, there is a recommendation in that older health professions education report focused on achieving consensus across the health professions on a core set of competencies that included patient-centered care, quality improvement, and evidence-based practice. Today, thinking has evolved to a next-generation focus articulated in the Care We Need report. For example, one of the actionable opportunities included there focuses on cultivating a culturally aligned, values-driven workforce by fostering competencies in safe, appropriate, person-centered care. Educators now could well be thinking about and adjusting learning opportunities, guided by unifying concepts articulated in the report. And I think that's particularly important because ultimately, achieving the vision embedded in today's report, achieving that vision by 2030, it's going to rely in no small part on these next generation providers. In summary, I've used examples of areas that I've worked in to illustrate that each of us brings different interests and expertise that build out from a broad foundation of quality and patient safety efforts. And advancing from that foundation, the Care We Need lays out a roadmap that almost regardless of where any of us are starting from, our efforts can be connected to it and informed by it. Furthermore, each of us might consider how the efforts of the organizations where we're employed and how the professional or consumer organizations with which we're affiliated could actively engage this work. Thanks, Alan.
Thank you so much, Mary and Carolyn, for your reactions to the report. I've gotten a terrific list of questions in, and we have some time to go through them, but I'm going to package a few of them together at a time so that you all can jump in as you see fit. I'm really interested in the patient-centered or person-centeredness concept, Shantanu, that you started us out with. I've always felt that that's something that we have identified but not made the kind of progress on that we need to. So partly I'm interested in how we reach some qualitative improvements in not just the lip service and the desire to be patient-centered, but actually make it happen. But then I want to fold in some of the questions that I received from the audience. Someone asked about scope of practice. The scope of practice can affect access to care and the ability of people to get care from the clinicians who they identify as the ones who would best meet their needs, whether it's nurse practitioners or pharmacists. So what's the role of scope of practice in assuring patient-centered care? And then a fairly narrow question, but I think an equally important one. A key element in the report is the importance of a single identifier, which enables you to follow patient care across the person, across settings. And the question is, who should be responsible for owning this and setting it up? So a broad array of questions, but they're all around the role of the patient and the ability of the system to respond to patient needs. Wonder who'd like to jump in and start providing some answers.
Well, I'll get us started, but certainly others should add in. And Mary, let me just say, my handwriting needs a lot of help. So if you have any contact info, I'll reach out to her. I think the person-centeredness, Alan, it's a great question and a great set of questions from the audience. I suspect there a few things will need to happen in order to really move us to person-centered care beyond just sort of speaking about it. First, I think, all things start with measurement, particularly at NQF. We will have to think about measurement differently. So right now, we view measurement really as a locus of care type approach. I think getting to measures that are much more patient or person-driven, that are reported by individuals largely, that are, at least as we talk about it, patient-reported outcomes, and who and what we are measuring becomes really critical. So we'll have to move measurement outside of the sort of the four walls of the hospital, for example, and into the community, I think, to really address a lot of person-centered need. I think second, of course, thematically, we have all addressed health equity in our comments and certainly in the report. I think really taking a person-centered approach will mean financing community-based organs differently, perhaps, to make sure that they are truly included in the system, that they are financed to help people get the various kinds of interventions and care that they need that, again, may not be traditional healthcare or medical care. I think the third, I think the scope of practice issue is a really interesting one. I'm not sure I could specify exactly what the scope of practice for a given clinician type should be, except that I think it needs to be as expansive as possible, as long as that's driven by real safety and quality outcomes and concerns, right? So I can certainly envision perhaps even more expansive scopes of practice than we have today. But as long as that is heavily tempered by ensuring that what the patient is getting is the right care at the right time, highly appropriate and extremely safe. That's not something that I can actually guarantee today. So that, I think, still would be a really forward-looking action.
So let me add to your list there, Shantanu. I think one of the recommendations of the task force really goes to this, and that's payment reform. The more that we drive payment towards population-based models, which really are based on those individuals and the whole person, the more we're going to get away from the incentives that drive things according to procedures and the fragmentation in the person's care that the fee-for-service model encourages. So I think the more we can move towards these population-based models of care, the more it will facilitate thinking in terms of person-centered care. I think just one other point I would make quite quickly is that in thinking about the scope of practice, we really should be thinking about how do various types of professional work at the top of their skills. How do we design the system, facilitate the processes of care, so that people are really working at that top of their skill level. And I think there's a lot of opportunities to change things so that does occur.
And Alan, if I could just build on what Shantanu and Ken just said, this is Carolyn. The one thing that I worry about is scope of practice gets into a lot of issues around boundaries. And I think Dr. Kaiser is right in suggesting that how we've been paying for care certainly reinforces that sort of boundary fights. Obviously, in the context of a public health emergency, we've been able to let go of a lot of that. And frankly, we've seen amazing teamwork and inspiring response from all health professionals. What I also think that we need to do, and I would hope that this work would include, is to identify gaps that aren't being met by any of the current professionals. And if you think about where some of our biggest threats to health are, a lot of that is chronic illness. And we can make the best evidence-based recommendations in the world and count all the right things. And if patients who have to live with this can't figure out how to make it work in their lives, this is an academic textbook sitting on a shelf like a tree falling in the forest when no one is around there. Certainly, there's a number of entities moving forward now where they're pairing coaches with doctors and nurse practitioners. And I think that what we need to do is start through a lens of what patients need and would benefit from and work backwards to get to scope of practice. I may have just insulted all professional disciplines, but that's my perspective.
I'd say just a word, if I could, first about scope of practice, since it's been raised, and then back to your broader question, Alan. In terms of scope of practice, I think clearly in response to COVID-19, CMS has provided some additional elasticity, if you will, in deploying other providers, nurse practitioners, for example, but other occupations as well. There is a wealth of evidence associated with quality and supportive of quality of care, that just staying with that as an example, that nurse practitioners deliver. I use it as an example, but only to say that as we look to garner more efficiencies in the healthcare delivery system, this really is about stepping back and ensuring that we are fully leveraging every workforce category that we possibly can, as effectively as we can. And I personally believe that there's been some capacity that hasn't been utilized historically in the pharmacy community, the physical therapist community, the psychology, counselor set of category of providers, and so on. And we can not well afford to leave anything on the table as we're trying to think about how we ensure access to high quality care. So this is sort of an all hands on deck, I think, moment, not just associated with COVID, but looking forward as well. In terms of patient-centeredness, I wanted to come back to that original question of yours and comment on it. I think that more attention needs to be devoted to supporting consumers' knowledge about how they can engage with their healthcare providers and in their healthcare delivery system. And that should occur before they get to a crossroads or to a crisis in their health, or a crossroads or crisis for someone in their family. I'm not talking about ensuring that a patient, for example, knows everything they need to know if they're newly diagnosed with diabetes, everything they need to know about that healthcare problem. I'm really talking about helping much further upstream patients, consumers, families to understand how they can effectively engage around health issues when they're interfacing with the healthcare delivery system. And I think that begins with articulating what are their goals around health, what their expectations are of the healthcare systems that are related to those goals, what they should be able to expect when they're interacting with the healthcare delivery system, and what they can do to ensure that those expectations are met. So really working with and building that in to help consumers engage very robustly with their health. There's a lot of work that I think ties to advancing patient-centered care in that stream of activity. I would also say one other thing about that I think this is an area we need to focus even more on in health professions education, that it becomes a part of, that is patient-centeredness and the concepts that surround it need to be built in directly in every patient and every simulated patient encounter. Needs to be taught, observed, evaluated. The focus may be on caring, for example, for a patient with respiratory problems, but hardwired into every single learning experience that's directed at patients and families, that focus needs to be really clear. The patient-centered components around that student learning experience. And frankly, some of this may require a refresh for faculty around the dimensions of patient-centered care, because even as we think about that concept today, we're thinking about it differently, even in this report, than it's been thought of and constructed even 10 years ago. I'll stop there.
So this is great. And I'll just say, Carolyn, if you offended all of the professions, it's because you actually said that we should build the system around patient needs, which is the definition of patient-centered care. So hopefully we can move past any sense of being offended and view this as a necessary engineering step. I received a couple of questions. Again, I'm going to sort of combine them. One person just asked, how are we going to measure progress you've created in this report, goals and objectives? But we also got a question about the past, there was a nice description, Ken, in the opening about the progress we've made and the progress we haven't. The question was, if you had to identify what the primary barriers were to success in the prior era, what would you consider that they were? And I think the implication of the question is, can we clear those barriers out of the way going forward?
Well, thanks, Alan. Let me take a stab at that, and certainly, hopefully, my colleagues here on the panel will chime in as well. I think the biggest barrier has simply been the culture of healthcare. Healthcare has historically been quite a conservative culture, one that has been centered around institutions, around the professions, and really hasn't been centered around the person, or to use somewhat out-of-date language now, the patient and the families. And that has been a kind of a hard nut to crack. So I think as we move forward, kind of along the lines of what Mary was saying a moment ago, we really have to start in or redouble our efforts in health professional training of all types to focus on the person and to focus on the new culture that has taken hold to some extent in some places, but is not a universal culture now that pervades the entire system. There are obviously other things such as payment that can facilitate or not facilitate that. One might argue, I think probably persuasively, that our continued use of fee-for-service doesn't necessarily facilitate many of the things that we're talking about in this report, where if we would, again, shift how we pay for things, it would catalyze and reinforce different types of behavior, which then leads to a different culture. Let me stop there and ask Shantanu or Carolyn or Mary to weigh in on this as well.
All right, Ken, I'll jump in. Carolyn, one of the big barriers throughout the progress we've made in getting to Hospital Compare and other platforms to show the public how we're doing has been a lot of tension between what consumers, how they would like to see the information, and how clinicians would like to see the information. So a clinician measure would be something like patients who've had a heart attack, who have no contraindications, should get a beta blocker. This is an old measure. Consumers want to know, am I getting the right care if I've had heart problems? And, this has devolved into more, tense kind of standoffs about that. I think there are also some technical challenges that we just haven't been clever enough, in some part because we didn't have the advanced technology that we have right now. So we've all, for many continuous measures like blood pressure, we've had, a cut point. If your blood pressure is below this point, then you're doing well. And if it's 1 point above, well, we had to have a cut point somewhere, so you're going to get quote unquote dinged. Whereas we could be, I think, a lot more creative in terms of how we share that information, both to ourselves to motivate improvement. How are we doing overall for this group of patients we're seeing, but also how might we improve in the future, and also to make it a little easier to understand by the consumers and patients we're serving.
Alan, I'll take up the first question in terms of measuring success. So look, the technical answer is that the report has measures for success built in, short, medium, long term. But I think if we take a step back, there's probably a different way of assessing whether or not we've really met the needs of the report, which is just having the knowledge that if I or any family member walks into a healthcare setting, that they will absolutely get the best, safest care. We do not, I don't think anyone that is a real observer of the system would have that kind of faith today. This comes from personal experience as well as professional, unfortunately, where, I think right now we often train patients and family members to be their own advocates. We often ask them to, ask questions about what's being given to ensure that there's no medication error. Those are all behaviors of a system that doesn't inherently trust itself. Where outside, where patients and family members don't trust it either. I think if we had that sense of safety, that sense of security, that sense of trust, we will know that we've gotten there. If we believe that, our insurance status or the type of insurance I have doesn't lead to different outcomes or different care, then we'll have gotten there. If I can believe that being a person of color or being a woman doesn't mean that I get different care, that's when we're there. You can look at the measures. We're a report writing organization. We've got measures. I think this is about trust.
So, Shantanu, I love that answer, and I want to use it as a point of departure for some additional questions, since this is the kind of conversation we're having. And it's this issue of reliability. That's another. You said it much more eloquently, but I think of it from an engineering perspective, sort of as reliability. And, in everything, in every field, and certainly we see it in healthcare, there are leaders who show the way. But then there's the challenge of making sure that, because not everyone can go to the leaders, not everyone can identify who the leaders are, we want to assure a foundation of reliability and trust that you're going to get the best care necessary. So I guess the question is, how do we make sure that the quality enterprise isn't just moving forward the front end, but is also carrying along those who aren't necessarily a part of that leadership cadre? And then to bring in a couple of questions that were also asked. Someone asked about the role of continuing education, that people sort of assume that that's going to be a form of assuring standards. We've already had a little bit of a discussion about education, but continuing education is a part of that. Received a question about burnout, which can be a huge barrier to reliable care, because it throws a monkey wrench into all of the systems. So how do we shrink the variability and make sure that you can't really be a part of this system if you aren't meeting some basic standards?
Well, let me offer one perspective, and it's just a narrow one, but on the measurement side, and I think we get at this in the report, are we really measuring what matters and what matters most in a system that such as Shantanu has described, where trust and consistency and predictability and reliability are all designed in and built into it. And I think there's plenty of evidence today to suggest that one of the contributors to physician burnout are the number of measures that are being required to be reported on. But it's not just the number, but it's the question about how important are they and how useful are they and how helpful are they really in directing people to do a better job. And I think many clinicians who are on the front line don't see the connection. And so as we move forward, we need to really focus a lot on honing the measures to things that truly matter to patient outcomes, which will probably mean that there'll be a reduction in the number of measures that may be broadly reported. We may have more for certain aspects, but we have to focus on the things that really matter as far as advancing person-centered care and safety and reliability and the things we've talked about.
Yeah, so Alan, this is Carolyn. I was glad that the question came up about continuing education, because I think that there is a very big opportunity there. So when I was at ARC, we had the opportunity to fund some work where continuing education was aligned very tightly with improvement goals for practices, for organizations, and so forth. But it was infrequent enough that it was something you could celebrate, because there just weren't all that many examples. Fast forward to 2020 and this pandemic, a number of my colleagues got together trying to figure out, how do you get information at a time when we know very, very little about this virus to clinicians on the front lines whose time to step back and sit down in front of a computer and go through a whole course. That's not going to be very practical. So I was really amazed and inspired by how people work together to actually make very short sessions accessible to people, whether they were working in an ICU or in the emergency room or even working the phones, so that they could get access to information as it emerged. And I think that we need to be thinking a whole lot more about how does that fit into healthcare systems, as opposed to thinking about, doctors will get their CMEs and go to their individual courses and so forth. It has to be aligned with what are we trying to do for the patients that we're doing. So instead of having radiologists flip through CDs at home, relaxing in their recliners, looking at different images of mammograms, which is a perfectly fine thing to do. Imagine if it was linked to problem cases in our practice, things that we miss that we wish we hadn't. That, I think, would make it far more meaningful and would get to the level of trust that Shantanu talked about.
Okay, I'm going to take two more questions and then we'll wrap this up. It depends how long your answers are, but I suspect these are not easy questions to answer, so we do have a few more minutes. There are a series of questions I've received that all center around the question of what's the scope? How focused in on clinical quality? How much are we zooming out? And there are two dimensions that have come up in probably 4 or 5 of the questions I've received. One is the relationship between public health and healthcare services, and Carolyn, you alluded to this in your opening comments. And the other is the role of social determinants of health, and the notion not just that they play a big role in outcomes, but that if health systems are going to respond to unmet needs, they have to build partnerships with other organizations. There has to be capacity to address those needs. There are huge resource issues associated with who controls the resources in trying to address those. So to me, these all center around a question of, is quality, I think we're trying to move quality out from just sort of this technical inside the healthcare system. If we move all the way out, maybe we're trying to take on more than we can. How do we think about what the scope of the quality enterprise should be, and how does the report consider this question?
I'll jump in if I could and make just a couple of comments about that. From my perspective, as you were reading those questions, Alan, it reminded me of part of the warning system that goes off inside cockpits of commercial jets. And there's a mechanical voice that says, terrain, pull up. And I feel like we're at that terrain pull-up moment in terms of really seeing the fractured world that exists between public health and healthcare delivery systems playing out right now in real time in terms of how the country is trying to manage into caring for patients with COVID-19. I think we've known this as healthcare providers and health systems and people in public health for a long time, but there's a chasm there that is adversely impacting the continuity, the sharing of information, the sharing of resources that should exist and currently does not, and we're sort of like headed straight into that mountainside. That takes on even greater significance when you deal in social determinants of health, as you just did. The good news in my mind is that when we think about patient-centered, person-centered care and how we're doing on that front, well, the good news is we're stepping back and taking a broader approach. So looking very carefully at increasingly at how to meet individual patients' social needs, working with them, how to address at a policy level social determinants of health, where health systems and public health and other social sectors are involved in that conversation. But this is a real challenge. Ultimately, I think quality is a prism through which this work needs to be viewed. You're right to ask how far out can the boundaries be pushed before that becomes murky, and those boundaries are wrapping in things that are features that are less relevant. But the questions and the work we need to do is incredibly timely. And if nothing before has shown us that, the environment we find ourselves in right now, as we are coming right into that terrain, and from where I think we all sit in our collective cockpit, it doesn't look good unless we make some very significant shifts. Quality is an overarching theme to that work.
So, Alan, let me. Your question brings back some memories, and I would just preface it by saying, kind of building on what Mary said, that certainly the recent events, the pandemic, the focus on systemic racism and other things really highlight, in some ways, a failure of 20th century medicine in that it separated clinical medicine from public health. And what the memory that it brings back for me was in 1972, as a first-year medical student at UCLA, I told the dean of the School of Medicine I wanted to get a public health degree while I was in medical school, and I would just, I'd do it at, off hours or whatever, and I'd work it out. And he said, well, why would you ever want to do that? I mean, what value would a public health degree have for you? And it literally, and by the way, this was a very revered figure in medical education as the dean of the school, but it took a year to convince him to allow me to pioneer what has continued to be a 4-year joint MD-MBA program there. And I only bring it out, though, because it really was a very tangible reflection of the schism and the separation of public health and clinical medicine that occurred for a variety of reasons over the course of the 20th century. And what I think has become patently evident now is the need that we have to bring them back together, whether we're going to address the social determinants and health equities, whether we're going to address issues like the pandemic and we could talk about many of the reasons, but it's clear that public health and clinical medicine have to really be linked much more closely than they have been in recent decades.
So this is Carolyn, and I agree with both Ken and Mary. I would just make the point that we do have some very great examples of success. I mean, one that comes to mind immediately is the HIV epidemic. If you've ever read In My Own Country, where Abraham Verghese figured out as an infectious disease doctor working in Tennessee that part of his job, yes, was to go to gay bars and talk to people about maybe this would not be a good time to be donating blood, long before we knew anything about the virus. And, that's only the beginning, just one example that stands out in my brain. Shantanu, I would bet one of the great privileges I have is serving on the selection committee for the Eisenberg Awards, which are given by the National Quality Forum and the Joint Commission every year. I would bet if we mined the examples that people have submitted, we would actually find a lot of exemplars. And I think one challenge is going to be, how do we showcase that as a way of motivating and inspiring action? So one that pops into my mind right now is an effort to improve clinical quality of care, but the outcomes they were looking at was success in school. This was obviously focused on children, but I would guess you would probably find a lot. And if that were put into the criteria for next year's awards, not telling you how to do your job, we would probably learn a great deal right now and build from there.
Carolyn, I don't mind if you tell me how to do my job. You come up with good ideas. We should definitely talk about that. Alan, one thing I'll just mention to your question about what sort of is the extent of the quality enterprise. I think it's a great question. I can't figure out how we draw a bright circle around quality and decide what's in and what's out. And I struggle with it because, frankly, so many issues, kind of lead to the common pathway of poor health outcomes. Including, as Ken pointed out, real substantive issues like institutional racism, which one might assume is outside of the quality enterprise, but it's hard to just assume that. I think I would feel more comfortable about leaving things out of the circle if we as a system, as a broad healthcare system, were far better at partnering with other systems, right? With the educational system, with community-based systems. And by that, I mean, we've got to get our house in order. Like, we don't have access to good data yet. Not everyone has access. It's not widely available. I think if we could get our house in order and be far better players in the overall kind of ecosystem of policy, and actually provide, resources and data and whatever we have at our disposal to these other entities, then I'd be far more comfortable saying, okay, we shouldn't solve those problems. There are organizations that can do that. But we're just not there. We're just not good partners yet.
Well, I thought we'd have time for 2 questions, but we really are at the end of our program. So as is always the case with a great exchange, we can't cover all of the terrain. But as we close, I just want to reflect for a moment. In addition to appreciating all that has been said here, I do encourage those who are watching to take a look at the report. Quality improvement is a lifelong endeavor. Our understanding and our goals for what we view as high quality will grow, and our standards will get higher as we achieve successes. And so this is a dynamic enterprise, and it needs to be, and we should not see this as something where we solve a problem. It's that we identify and tackle a problem and then identify the next one, so that with each successive phase, we feel better and stronger about what we've achieved. For me, reading the report and listening to you all, I go back to where I started, which is the progress, not just in actual quality and safety, but in our conceptualization and understanding of quality and what it takes to achieve quality has grown dramatically in the last couple of decades. And the intellectual contribution of this report and the hundreds of people who contributed to it is to assure that we continue to set our sights high and that we continue to look carefully at what is needed in order to achieve the high standards that we set for ourselves. From my read, this report has done exactly that. And this conversation shows that it can be used as a starting point for many rich conversations, ones that we'll have to continue beyond today. So I am going to say that I am incredibly grateful to Shantanu, to Ken, to Mary, to Carolyn, to all of you for your thoughts, for your contributions, and Ken and Shantanu particularly having played such a lead role in the report, the contribution you're making to the field. I thank our audience for submitting some really terrific questions. I'm sorry I couldn't get to them all, but I'm glad you're engaged, and we are appreciative of your participation in this event. And with that, we hope that people will make use of the resources here, and we'll look forward to our next conversation. And for now, we are adjourned.